Okay, so this week we are also going to talk about assessment of labs, and we want to make sure that you have the right mindset in dealing with labs and older adults compared to younger adults. So that'll be our focus. What's different with older adults compared to those younger persons? So interpreting laboratory findings is a bit different, and it does require some specific diligence so that you understand the differences between normal age-associated changes and potential problems or pathological states. So things that you'll see that happen as an individual ages will have the number of stem cells will become decreased in the bone marrow, and we also slow down that red blood cell production. Our erythropoietin, especially exogenous erythropoietin, is less effective in stimulating more red blood cells. So that means our red blood cells count will be lower, and it may even shift lower than that because we're not stimulating as much reproduction. Our lymphocyte function, especially cellular immunity, also decreases, and that means that we'll have increased immature neutrophils, a left shift, rather than an increase in total lymphocytes when someone has an infection. The adhesiveness or stickiness of platelets increase. So our platelets are even more apt to become lodged or stuck in a place that has a slight abrasion or plaque buildup. And that increases primarily the risk for cardiac events, but it can increase the risk for blood clots as well at any place in the body. And then the hemoglobin and hematocrit, they decrease slightly, but they usually stay within the normal ranges. So if you see a low red blood cell count, that may be considered normal due to age in an 85-year-old, and on the low side hemoglobin and hematocrit would be considered normal, and that increase immature neutrophils, the left shift, would also be considered normal. So what we want to look at as well is some disturbances of electrolytes, and potassium is one of the really important ones because potassium has so much impact on so many different parts of the body and on how the electrical impulses are transmitted from one site to the next, and especially in the myocardial system. So when you see that your patient has low potassium, less than 3.5, they're going to have fatigue, constipation, muscle cramps, general weakness. And then when it goes high, you're going to see weakness, muscle cramps and pain, increased GI motility. So you might see someone with diarrhea, bradycardia, and eventually cardiac arrest when it's high enough. What you need to really understand with potassium is that low potassium, hypokalemia, potentiates the effects of digoxin. So if your patient has a low potassium level and they're on digoxin, you want to make sure that you also check a dig level. Sodium imbalances, usually we end up with either too little sodium or too much water. So for hyponatremia, our signs and symptoms can vary from patient to patient, and it usually depends on how quickly that sodium level changes. The first signs are neurologic, so headache, irritability, some type of confusion, muscle twitching. You know, when you get that little twitch in your eye and it just goes on all day long, eat a banana. Weakness, and then as it gets more pronounced, then nausea, vomiting, anorexia. Hypernatremia is that way too much sodium in the diet or dehydration. It's less common in older adults than hyponatremia. And signs and symptoms are usually neurological, again, because those fluid shifts really impact the brain cells so easily. So restlessness, agitation, anorexia, nausea, vomiting, but you might also see flushed and feverish individuals. And then things progress from there: weakness, lethargy, confusion, stupor, seizures, and coma, until we end up with death. Calcium and phosphorus you need to make sure that, remember that they are inversely related. If I increase my calcium level, the phosphorus level is going to decrease, and vice versa. The kidneys trigger a secretion of one or the other depending on the level. We can measure calcium levels to assess parathyroid function and also calcium metabolism. Only about 1% of calcium is stored in the blood. The rest is in our bones and teeth. However, if our calcium level becomes low enough, we can pull the calcium out of our bones to help supplement what we need in our bloodstream. 50% of serum calcium, so the amount that is stored in the blood, is bound to albumin levels. So if you can adjust your serum calcium level if your albumin is less than 4 grams per deciliter. You use your serum calcium level and then you add 0.8 times 4 minus your serum albumin level, and you'll get that corrected calcium level. Impaired calcium metabolism is very common with age, and then in that point the bones start to release calcium to maintain those serum levels, and that's where we end up with these really low levels as far as the calcium goes, and that can impact muscle, and it could impact electrical contractions. So albumin is a good sign of malnutrition, and it certainly increases with aging and illnesses. A person might be healthy but still be malnourished. They might look healthy and still be malnourished. So we need to check albumin levels. The normal levels are listed here. I don't expect you to memorize those, but you should know that low albumin levels can indicate things like malnutrition, obviously, but it could also indicate dementia, heart failure, cirrhosis, or some other inflammatory process. In long-term care, you should know that labs are collected much more infrequently than acute care. But if your resident begins to show changes of new or rapid onset confusion, this may be the first sign that something's amiss. So that would be a time when we said, hey, we might need to get some labs and see what's going on with this individual. Do a comprehensive assessment, check for clinical signs and symptoms, and then give that doc a call. Also remember that older adults are very susceptible to fluid and electrolyte changes. So sometimes this is because they can't access fluids without help. Sometimes it might be they can't tell someone they're thirsty, or they don't become thirsty as quickly. Also, the physiological changes in hormones like decreases in ADH, renin, and aldosterone can impact fluid and electrolyte levels. This is the end of this section, but don't forget to access the video, which is also testable content. That will be on the pages slide in Top Hat, and also complete those questions in Top Hat as well.